You're listening to This Week in Cardiology from theheart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.
Hi, everyone. This is John Mandrola from theheart.org, Medscape Cardiology, and this is This Week in Cardiology for April 11th, 2025. This week, a little more ACC and ERA review, plus a bonus. The trials include the TAPIT, STRIDE, FreshUP, and single-shot champion trials. I had a lot of fun with these trials. There's some interesting things to discuss. I am back home and recovered from my week in Vienna and Amsterdam. Sadly, though, Kentucky is almost underwater. We had biblical rain while I was in Europe, and today is the first day that the river and lakes are receding. The first trial is the TAPIT trial. PhD candidate Sina Glagard from Copenhagen led the TAPIT trial. This is a simple, elegant RCT comparing thoracentesis upfront plus medical therapy versus medical therapy alone in patients with heart failure and pleural effusion. If you take care of patients with acute congestion due to heart failure, you know this dilemma. The patient has obvious congestion. There's dyspnea, edema, neck veins, rouse, decreased breath sounds. The patient has known left ventricular dysfunction and an elevated BNP. Now the chest X-ray shows a large pleural effusion in addition to the acute congestion. For decades, my entire career, I have recommended draining that effusion through a catheter. Back in the old days, we did it ourselves with a needle in the vacuum bottle. Now, patients go to radiology and get ultrasound-guided drainage. In my idea, perhaps it was yours too, was that thoracentesis is a simple procedure that speeds the decongestion, expands the lung, and patients come back feeling better. Now, our pulmonologist had admonished me a few years ago that there was scant little evidence for the extra procedure, and I should consider just using diuretics. And I said, no way, come on, thoracentesis helps. I mean, you can see the darn fluid in a bottle that was once in the body squishing the lung. Plus, patients say they feel better. Well, Dr. Glagard and her colleagues set up and ran an RCT. 135 patients who had acute heart failure and effusion. 1-to-1 randomization to thoracentesis plus meds versus meds alone. And the primary outcome was one of my favorites, days alive and out of the hospital. I really liked that outcome. They also looked at quality of life, length of stay, and mortality. These patients had a median EF of 25%, so these were heart failure patients. They were also older, age 80 to 82. More than half the patients were considered frail. They screened only 255 patients and enrolled 135 patients. And the results? Now, before I say the results, I should add a boom. There was no difference in days alive out of the hospital, 84 versus 82. There was no difference in length of stay of the initial hospital stay. There was no difference in 90-day mortality, and most important, no difference in quality of life scores. Diuretic dosing was not different, weight loss not different, nothing was different. Except there were 5 pneumothoraxes in the thoracentesis group, and 1 had to be drained with a chest tube. And 20 out of the 80 thoracentesis participants experienced minor complications or discomfort during or after the procedure, resulting in an overall complication rate of 26%. So my comments. Circulation published a trial, but it should have been in New England Journal of Medicine. It should have been covered in the New York Times, New Yorker, wherever. This is a simple, elegant trial that reversed a common practice, at least a common practice in my area. I love this trial because it proved me wrong. I had been fooled. Sure, I knew acute heart failure required intense diuresis, but I had also thought that when there was substantial effusion, thoracentesis aids the process. That big bottle of yellow fluid that gets pulled out looks impressive. The post-chest X-ray without the fluid also looks impressive, and patients come back feeling better. It all made perfect sense. But, as it turns out, so often in medicine, what makes sense does not always pass muster in an RCT. TAPIT wins the week not only because it informs and reverses a common practice of thoracentesis for heart failure, but more so because it teaches crucial evidence-based medicine lessons, and that is you have to submit common practices to proper trials. Now, we don't need to study empathy, compassion, taking time to sit down and listen to patients, but surely when we propose sticking needles into people and potentially causing pneumothoraxes, things like this should pass an RCT test. This hadn't been done until now. Decades we've been doing this procedure, and it hadn't been proven. Now, there's a few caveats. Of course, there were important exclusion criteria to the TAPIT trial. Effusions that could have been due to other causes, such as cancer or infection, these patients were excluded. And of course, there's still a role for a diagnostic thoracentesis, that is, sticking a needle in and sending the fluid to the lab. Also, patients with massive effusions that were more than 2/3 of the pleural space were excluded. So the neutral results of TAPIT should not apply to these patients. But my practice changes today. No more routine, upfront thoracentesis for patients with heart failure, and thanks to the team in Denmark. And one final comment. One of the most important first questions I like to ask when looking at a study manuscript is this: was the study science or marketing? TAPIT was clearly science. Now I'm going to show you something that's closer to marketing. This is the STRIDE trial. Now, there aren't many good options for patients with claudication and diabetes. The drugs are old, modestly effective, and certainly limb revascularization is a bad idea in most cases when done for claudication. Now, the company that makes the GLP-1 agonist semaglutide had an idea. Perhaps it would work for claudication in patients with diabetes, and it's a decent idea, actually. The problem with STRIDE is not the idea, it was how the idea was tested. So the STRIDE investigators screened more than 1,300 patients in numerous centers and countries to enroll about 790 patients in an RCT comparing semaglutide to placebo for the treatment of claudication. The inclusion criteria of STRIDE were quite strict. Patients had to be able to walk pain-free for 200 meters on a flat surface at a speed of 3.2 kilometers per hour, but they also had to have symptom-limited claudication by 600 meters and a fixed incline of 12%. The chosen primary endpoint was the ratio to baseline of the maximum walking distance at week 52, 1 year, measured by the constant load treadmill with a fixed speed and fixed incline. They had numerous secondary endpoints, including physical function questionnaires. These patients were 68 years old, 27% were female, and the median BMI was 28. About a third of patients with these, remember, diabetics, were on SGLT2 inhibitors. The primary endpoint was positive for semaglutide. Of course it was. The estimated median ratio to baseline and maximum walking distance at week 52 was significantly greater in the semaglutide group than the placebo group. It was a 21% increase in maximum walking distance versus an 8% increase in the placebo arm. It ended up being an absolute value of about 26 meters or 87 feet more distance with semaglutide. Semaglutide also improved the pain-free walking distance, a median of 14 meters. Quality of life scores improved more with semaglutide, though the differences were modest. Now, participants in both treatment groups lost weight between baseline and week 2. There was a mean difference of about 4 kilograms in the semaglutide versus placebo arm. The authors concluded that semaglutide increased walking distance, and they called for more research on the mechanisms of benefit, as well as further trials in patients without diabetes. Okay, my comments. The two main problems with STRIDE was A, unblinding of treatment arms and likely placebo effect, and B, an extremely modest increase in exercise time. And look, it's nobody's fault, but the GI symptoms and weight loss that comes with GLP-1 drugs leads patients to know their treatment assignment. And given the tiny improvements of meters increase in exercise time, you could easily say this was placebo effect. What I can fault the trial authors for is why they did not do a blinding index or treatment guest questionnaire or some measure of blinding. Just do the test and let our readers know whether patients knew their treatment assignment. The second issue was the increase in exercise time over placebo in STRIDE was modest, very modest, and similar to silostazol. Thus, it's hard to get excited about using a very expensive agent for claudication. Now, the GLP makers, they don't have a shortage of cash. They could design and conduct a far more robust study. I'd want to see one that measures hard endpoints and the quality of life as secondary endpoints. Now, I've thought about the issue of blinding in placebo-controlled GLP-1 drug trials. I have not come up with an easy answer because I think unblinding happens. For instance, the Summit HF trial of tirzepatide and HFpEF also had a quality of life primary endpoint that was positive. But again, there is the matter of placebo effect. Perhaps we simply cannot rely on subjective endpoints for GLP-1 agonists. Therefore, I don't think STRIDE rises to the level of expanding the indication for GLP-1s in patients with PAD, and I think this is a good example of a trial destined to be positive by design. Okay, third trial is the FreshUP trial. This next trial challenges yet another dogma in cardiology, and that is fluid restriction in patients with heart failure. 2 years ago, Dr. Justin Ozekowitz presented and published results of the sodium HF trial, which busted the dogma of sodium restriction for patients with heart failure. This year, at ACC, we learned results of the Dutch-led FreshUP RCT, first author Joop Herman, which tested fluid restriction in heart failure. Nature Medicine published a paper. This was an investigator-initiated trial conducted in 7 Dutch sites. The intervention was a 1,500 milliliter per day fluid restriction versus standardized lifestyle advice. Now, any patient with class 2 heart failure was eligible, and there was no EF restriction. The primary endpoint of FreshUP was a KCCQ at 3 months. The key secondary endpoints was thirst distress, which I did not know existed as an outcome measure. There were 504 patients randomized. These were 67-year-old patients, 2/3 male, and 90% of patients had class 2 heart failure. Class 2, about half had HFrEF and half had HFpEF. Importantly, the mean KCCQ was 77. That's an important point. This is a pretty good KCCQ at baseline, and it really indicates minimal limitations. Self-reported fluid intake was 300 milliliters higher in the liberal intake arm. It was about 1,800 versus 1,500, roughly. The KCCQ after 3 months was 74 in the liberal fluid intake versus 72.2 in the fluid restriction group. That mean difference after adjustment was just 2.17. And the confidence intervals were minus 0.06 to positive 4.39, and the p-value was 0.06. Ouch. The perceived thirst distress was lower in patients randomized to liberal fluid intake. It was again 16.9 versus 18.6, and again, this was statistically significant. As for clinical outcomes, the trial was not powered to assess things like hospitalization or CV death. There were small numbers of events and no substantial differences. The authors in their discussion discussed previous studies of fluid restriction, of which there were only a handful, very small numbers of patients in heterogeneous populations, and these very small studies had given mixed results. Nothing the size of FreshUP had been published. So my comments. At first look, the mean difference of only 2 points in the KCCQ is small, especially since the scale goes from 0 to 100 and clinically important gains are thought to be around 5 points. The mean difference in FreshUP is only 2, but the confidence intervals go from 0 to 4.4. Now, previous studies have found that when the mean difference is 2, there can be many patients who have greater than 5-point increases. Yet the authors concede that since the result is non-significant, it would be inappropriate to state that liberal fluid intake leads to a higher health status. However, I do agree with the authors who say that the observed difference does make it very unlikely that fluid restriction results in better health status. What's more, the authors also argue that there was no signal of harm from a liberal fluid intake. I like the study, and I like the effort to try and sort out the business about fluid restriction. But I don't think FreshUP reaches the level of busting a dogma for the following reasons. First, they enrolled a group with very mild heart failure. Most of the patients in this study had class 2 symptoms. At baseline, they had very high KCCQ scores, and they were relatively young in age. The second issue, the difference in intake was minimal, only 300 cc's. That's like one small bottle of water. I don't think you'd expect much difference in quality of life from this much difference in fluid intake. As for safety, there were very few events, as you'd expect in a trial enrolling a healthy group, so I don't think you can say much. In sum, therefore, I think we can say there was no worsening of quality of life, there was a trend towards better quality of life, and nothing bad happened in these mild heart failure patients who had a liberal fluid intake. I think you'd really want to repeat such a study in patients with a bit more heart failure severity, perhaps patients who have a mildly low sodium level. These patients are often put on a strict, and I'll say miserable, fluid restriction, and I wonder if that's necessary. Nonetheless, limitations aside, congratulations to the authors for doing such an important and relevant study. All right, next topic is more on that new kid on the block, pulse field ablation for AF ablation. 2 studies came out recently looking at the value of PFA or pulse field ablation. Now, even though this is an EP topic, it's worth talking about here on a general podcast because PFA is a big deal. Nearly every week I have a patient ask about it, and it's a new thing in EP, and I think it has changed AF ablation. At the European Heart Rhythm meeting, Dr. Tobias Rieklin presented results of the single-shot champion trial. New England Journal of Medicine published the RCT comparing PFA ablation with cryoballoon ablation for patients with AFib. Now, it's important to set out first that PFA is not one thing. Numerous companies are developing different PFA systems. Many, but not all PFA, include catheters that offer multipolars, catheters that ablate large areas. And this differs, of course, from point-to-point RF ablation with a small tip catheter. But there are iterations of PFA coming where you can do point-to-point. But what we're talking about now is the Boston Scientific pentaspline system, which is sort of a single-shot system that ablates large areas versus standard old-school cryoballoon. Single-shot champion was a relatively simple, elegant trial of 105 patients who had PFA, 105 patients randomized to cryoballoon in 2 Swiss centers. These were expert ablaters who had a long experience with both systems, and that's an important difference from some of the early regulatory trials of PFA. For instance, I'll just mention the Advent trial, where PFA was compared to thermal ablation, but the American operators in Advent were completely new to PFA. Now, another important point with single-shot champion was that it was an investigator-initiated and controlled study. Boston Scientific gave funds, but they had no say in the trial procedure, so it was the authors doing the study. The mean age of 64, CHA2DS2-VASc of 2, primary endpoint was first recurrence of AT or AF between days 90 and 365, so there was a blanking period for the primary endpoint. All patients in this trial had loop recorders. Curiously, the authors used a non-inferiority design. They allowed a margin of 20 percentage points for the primary endpoint. Now, more on why I call this curious later. The main result is a recurrence of atrial tachyarrhythmia was observed in 39 patients in the PFA group versus 53 patients in the cryo group. That is 37.1% versus 50.7%. That difference is minus 13.6 percentage points. And the 95% confidence intervals went from minus 27 to minus 0.3. That p-value for non-inferiority was very significant, less than 0.001. The p for superiority, however, was 0.046. And the hazard ratio was 0.66. The confidence interval here was from 0.43 to 1.01. And I think the P for superiority right at 0.05, that threshold relates to the upper bound nearly hitting 1. Now, since I've been a kick lately to stop reporting on the blanking period, I will link again to my editorial co-authored with Drs. Foy and Rouzier. The Swiss team did report results right after from day 1 of the procedure, which I like. Here, PFA stood out even more, with a difference of minus 20 percentage points better on the time to recurrence, with confidence intervals ranging from minus 33 to minus 7%. Now, that's because the PFA had far fewer recurrences in the blanking period. More on that later, too. The mean AF burden in the 2 groups from day 1 to day 365 was 1.6% versus 2.5%. So very low and not much different. Procedure times were shorter with PFA, 55 versus 73 minutes. Serious safety events were infrequent, but they did occur. One patient in the PFA had a stroke, and there were 2 patients who had tamponade leading to drainage in the cryoballoon arm. Interesting, repeat ablation procedures were done in 16 patients in the PFA group and 10 patients in the cryoablation group, and that rate ratio was 1.60. Now, my comments. First, we have to congratulate the Swiss teams. They did the trial on their own. They were curious, and instead of reporting retrospective data, they did a proper prospective randomized trial. Now, they did receive some funding from industry for the event recorders, but they did all the work on their own. Now, in the science versus marketing dichotomy that I talk about, this counts as science. They asked an important question. That is, we really do want to nail down the efficacy of PFA versus the standard. Now, we should have more of this in the cardiology community. That is, people doing trials without much industry support. Now, this is also a better comparison than the previous PFA versus thermal ablation trials because A, all patients in single-shot champion had loop recorders, which makes assessment of AF recurrence much more accurate than intermittent Holters, and B, the operators were experienced in both PFA and cryoballoon. Now, on the matter of the results, I think it's fine to say PFA was non-inferior to cryoballoon. I would be far less excited to say PFA was superior, however. The majority of the benefit seems to occur in the blanking period. PFA has less recurrence early. After 90 days, the Kaplan-Meier curves for AF recurrences are parallel. And I think this sort of fits with the prior PFA information, which seems to have less early recurrence. Some even suggested at ERA that future PFA trials could be shorter because there was so little differences after 3 months in the Kaplan-Meier curves we could probably just follow for 3 months. While time to AF recurrence was better with PFA, I think the better measure of success is AF burden, and this was low in both groups and not substantially different at 1.6 versus 2.5%. Now, here are a few other reasons to be doubtful that the trial establishes superiority. The cryoballoon results in this trial are the lowest reported yet in other trials. Now, the authors suggest that this was bad luck, as 1 in 5 patients in the cryoballoon arm in this trial had a common ostia left pulmonary vein, which that makes cryoballoon ablation difficult. And that could be true. Also, 2 of the cryoballoon patients had their ILR removed and the data censored as an endpoint. Now, that doesn't sound like a lot, right? 2 patients. But the margin for superiority was very close, and there were only 100 patients in each arm. I'm also curious why 6 more patients in the PFA arm had reablation. If you have better results in the PFA arm, like they were shown, you'd expect reablations would be less. Now, finally, I'm also curious to why there was a decision to use non-inferiority. The indication to study something in non-inferiority, it doesn't seem super strong here. Recall that for something to be tested for non-inferiority, you'd want that new treatment to be, let's say, less expensive, which is not the case for PFA, or you'd want it to be less invasive or perhaps convenient, and I don't really think that's the case for PFA. So I suspect that the choice to do non-inferiority had to do with pragmatism, as you don't have to have as many patients in a non-inferiority than you do as a superiority trial. But overall, this trial does show results largely similar to Advent, and Advent found that PFA and thermal ablation performed quite similarly. The remaining questions, I think, are whether different PFA systems do better. This Boston Scientific system used in the trial was a first-generation device, and different companies with different catheters and different electro algorithms may make ablation better. There's a lot of iteration going on in the PFA space. The answer, of course, to find this answer, is to do it the Swiss way. Don't just report retrospective, non-random comparisons. We should have more prospective randomized trials. Now, there is one related PFA study that I wanted to mention. I missed this in January. This is called the Manifest Redo study. I think it's relevant to the trial I just discussed, and I can do this very briefly. The first author of Manifest Redo, Daniel Scher, along with many big European operators, reported 427 patients who had repeat ablation due to clinical recurrence after a PFA ablation, and again with the Boston Scientific pentaspline system. This was done in 22 centers, and the key finding of the Manifest Redo study, this was in January in EuroPace, only 45% of patients who were taken back to the lab for clinical recurrence had all their PVs durably isolated at the beginning of the repeat procedure. So that means that more than half of patients ablated in really good European centers with PFA had PV reconnection. The use of a mapping procedure in the initial procedure was associated with durable PVI. No one pulmonary vein stood out as particularly difficult to ablate. The recurrences were sort of equally distributed among the 4 pulmonary veins. Also notable here was similar durability of posterior wall isolation. So with PFA, we are more often doing posterior wall isolation because we feel like the esophagus is out of the picture and we don't have to worry about atrioesophageal fistula. So more operators are adding posterior wall isolation when they do PFA. However, this redo study found that 45% of patients who had posterior wall isolation also had reconnection of the posterior wall. So we're not that great at durable isolation of the PVs or the posterior wall, even with this first generation PFA system. And I think all of this looks quite similar to thermal ablation. But again, I'll reiterate that there's a lot of changes and iteration going on in the PFA space, and it may get better. Finally, I was going to do the FAME 3 5-year results, which made headlines because in the primary analysis of the CABG versus FFR PCI trial, PCI did not even reach non-inferiority against CABG, but now at 5 years, headlines have PCI as catching up and being just as good as CABG. Well, I'm not sure that's right. There was some serious nuance involved, and I will have more on that next week as I'm pretty much out of time today. So that's it for this week in cardiology. As always, I'm grateful that you listened. Thank you. And remember, my friends, if you like this podcast, please take the time to give us a rating, write us a review. This helps others find us. If you have questions, you don't agree with something, write me a note, write a comment on the website. I enjoy the comments and learn from them. Until next week, this is John Mandrola from theheart.org, Medscape Cardiology.
You're listening to This Week in Cardiology from theheart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.